MR scan of an 88-year-old male who had this incidentally detected pancreatic abnormality on a CT. And the FNA was negative in this case, but on ERCP, they found a bulging papilla sign. So they requested an MRCP on this case. And these are the coronal haste images that show diffusely dilated main pancreatic duct. And as we come closer to the ampulla, the duct is significantly dilated, and we see this frondy soft tissue growing within the duct. These are the axial haste images. Again, same findings, dilated main pancreatic duct, and in the head area, there's significant dilatation of the main duct and some of the side branches, and we see this frondy soft tissue growing within the ducts. So this one will be main duct IPMN, and given presence of soft tissue within the dilated duct, this will be worrisome for malignant transformation. This is a post-contrast axial T1, and that shows that nodular soft tissue growing within the dilated ducts. And we notice that the soft tissue doesn't enhance as intensely, just very poorly enhancing soft tissue within the ducts. And this diffusion images. And these IPMNs with malignant transformation diffusion images are really not helpful in telling the degree of or to identify foci of malignancy, because mucinous malignancies typically don't show a whole lot of restricted diffusion. And these were the MRCP images that show the dilated duct and the main duct, dilated side branches, and a lot of soft tissue within these ducts. So this one was a case of IPMN with malignant transformation. Next case also, same diagnosis, just trying to show these cases because all of them looked pretty similar. So it's striking similarity in the imaging findings of all these cases. So again, dilated main pancreatic duct, and you see this frondy soft tissue growing within these dilated ducts. So that's the main duct extending towards the ampulla, one of the side branch that is also dilated and has this soft tissue growing within the duct. Axial T2 fat set images. Again, we see that intermediate signal soft tissue along the ducts. This is post-contrast. Again, showing this poorly enhancing frond-like soft tissue growing within these dilated ducts. The other thing is on imaging, it's hard to predict the degree of dysplasia in these lesions. Some of them, like path is more specific. They'll tell you if these are associated with low-grade dysplasia, high-grade dysplasia, or there is an invasive component. The only definite signs of invasive malignancy will be if you see like soft tissue extending beyond the pancreas, invading the surrounding structures, or if they are malignant lymph nodes, then there are high chances that there will be a component of invasive adenocarcinoma associated with these lesions. So in this case, the path showed malignant transformation, but only 0.4 centimeter focus of invasive adenocarcinoma. The margins was negative, there were no lymph nodes, so this was called as a T1A lesion. And after they do Whipple surgery because they're usually localized to the head area and it's easier to resect them that way. So
that's a really nice example.
Yeah. So do you want me to show other cases, or I think? So just some quick points that we have already discussed most of the stuff. So IPMN defined by WHO as intraductal papillary mucin producing neoplasm, 3 subtypes, main duct, side branch, and combined. And these are pre-malignant. They can develop foci of invasive adenocarcinoma in them. And the important differential diagnostic, which I think we've also discussed this couple of times in our conference, the difference between IPMNs and mucinous cystic neoplasms. IPMNs are more in the head, and all the examples that we saw were all in the head area. These are more common in elderly male. They will show connection to the main pancreatic ducts, whereas mucinous have no ductal communication. IPMNs don't have any distinctive stroma in them, and mucinous cystic neoplasms have ovarian type stroma in them. And in IPMNs, we see this protrusion of main papilla in the duodenum, which was there in all 4 cases that we saw. And just found this very interesting, the histopath correlation. So mucinous cystic neoplasms are more well-defined locular lesions, and this is on path that we see. This is the epithelium, and then there's malignancy that has invaded and Again, even mucinous cystic neoplasms will have low-grade dysplasia, high-grade dysplasia, or invasive adenocarcinoma. The path differentiation or the classification is same for both. And in this one, it's extensive IPMN, but it's all growing in the ducts. So invasive adenocarcinoma is when we see malignant cells that get into, or these purple cells that will get into this pink stroma. And that's when they say that it's a high-grade adenocarcinoma. And as I said, or we discussed already, WHO classification is IPMN with low-grade dysplasia, with intermediate grade dysplasia, high-grade dysplasia, or with invasive cancer. And if it's an invasive cancer, it can be of two types: colloid type, which is mucinous non-cystic and has a better prognosis, than if the invasive component is tubular or ductal carcinoma. So example of low-grade dysplasia where there is not much of layering of the epithelium, and high-grade dysplasia when there are multiple, like more nuclear pleomorphism or more purple stuff. That's how I think look at that. But there is no tumor cells growing into the stroma. So this one doesn't have any invasive adenocarcinoma. And these are your guidelines, 2012 International Consensus Guidelines of Fukuoka guidelines that tell you, or the features that suggest presence of high-grade malignancy or high-grade dysplasia or invasive component in these tumors. So if the main duct is dilated more than 1 centimeter, or if we have more of solid enhancing mural soft tissue in these, and some of the worrisome features are branch duct IPMN more than 3 centimeter, dilated duct, which is between 5 to 9 millimeters main duct size. If you have non-enhancing mural nodules, if you have thickened enhancing wall, or if you have focal stenosis of the pancreatic duct with distal parenchymal atrophy. And this was another radiographics article that mentioned all these features, and there were some other features that the earlier guidelines don't talk about. If you have more calcified intraluminal contents, because all that mucus that is retained in the dilated ducts can get eventually calcified. And if you get biliary obstruction with these cases, and obviously invasion of surrounding organs, and if you have lymph nodes, like malignant lymph nodes associated with these lesions, these are definite signs of invasive adenocarcinoma. But again, on imaging, it's hard to differentiate. All we can say that there are high chances of malignancy when we see this frondy soft tissue, but what we can't tell is how much is the, like, is it just high-grade dysplasia, or there are foci of invasive adenocarcinoma in these lesions. That's all I have.
Great summary. And yeah, like sometimes that whole like colloid carcinoma variant and stuff, like people will say, like, hey, what's the point of learning that? Or like, can we actually tell that on imaging? And I would say, like, we can't tell it on imaging, but it kind of explains why often the path is not as bad as these look, even if they can be large with large soft tissue components. They might not have as much either invasive adeno, or if they have that colloid type, it's a better prognosis.
Yes,
I think it's like a 50% 5-year versus like 5% 5-year for a ductal adeno.
Yes, and it just helps us to understand how these cases are eventually managed and the rationale for following up these cases, like for how long we should follow them up, or what should we be looking for on these follow-up cases. So it just really helps us to understand how.
So how long should you follow them up?
For these, I think the guidelines are same as ACR, so up to 9 to 10 years.
Yeah, but some people would say if you have a cancer in an IPMN setting, you've got now both, like, so for just a T1 cancer, they follow up for 5 years. And then if it's an IPMN associated cancer, they might follow them for life, depending on how old the patient is, but because the whole rest of the gland is like at high risk. High risk.
And then we also say that the side branch IPMNs are followed because they also have a high risk for developing pancreatic adenocarcinoma. So we are not just following them for their malignant degeneration, but development of associated pancreatic ductal adenocarcinoma.
Yeah, the whole gland is like at risk, yeah.
So can I ask folks a question about that? This is Manjul, sorry to jump in late. But so what do folks do in terms of protocoling these with or without contrast, especially now with COVID and trying to reduce MR time?
Are you asking about like follow-up of routine IPMNs, like tiny, small ones, or like these kind of more malignant looking?
My question is in all the above of what you just said. Like from a workflow perspective, it's very hard to know when protocoling these cases whether or not they are big and complex and have been growing and then should be given contrast. And then what about that concomitant risk of pancreatic adeno-CA? Do all these patients get, let's say it's a 3 millimeter IPMN on the side or something, you're just following again. Does that patient get contrast? I mean, there are a lot of literature which suggests no, but on the other hand, from a workflow perspective, I'm having a hard time deciding how to teach someone to protocol like that without their mind.
So I think this comes down to whether or not you have a good workflow for abbreviated protocols, because those abbreviated protocols often drop all the post-contrast sequences, and you can just get like a fast 10-minute scan.
Exactly, we do.
So if you have that workflow, I would say if you have prior scans and it's 3 millimeters, I mean, it's a judgment call at some point, but all those small lesions, older patients with small lesions, I would definitely put them into a non-contrast abbreviated protocol, regardless of COVID. And then, the ones that are more on the move, or if you don't have any prior imaging showing any kind of stability, that's where I would do a full scan.
Yeah, I mean, I think we agree in essence with you, but we're struggling with the number of cases we have to, go to that level of depth for every single case protocol, because there's a tremendous number of these,
Yeah, I don't know. We haven't cut back or changed because of COVID. Have other people, I mean, if anything, they're we need to recover our financial losses numbers and scan everybody. So we're scanning fully at this point. We're not making different protocol decisions based on COVID.
Exactly, us too. So in order to scan all those people that were backed up, the idea now is to shorten the time slots, to allow, to at least make up the time for, cleaning the room and turning it over and social distancing in the waiting room, et cetera. So I was just curious if others are opting to do these non-contrast in more situations or not, because we've been struggling with that.
Mm-hmm. Well, that's probably smart, but yeah, we've basically just been using the same decision tree.
Okay, thank you.
Yeah. Victoria, do you want to go?
Sorry, it takes me a second to unmute. Yes, of course. I think Gitanjali, you need to stop sharing. Gitanjali?
I think we see your screen because it looks like a new.
No, that's not my
screen. Sorry.
No, I think it was still, I just stopped sharing the screen.
Okay. Advanced. Push the screen. Okay, can you see it?
Yes.
Okay. So we'll start with a sort of a theme, I guess. When I do this, does it zoom in on the screen or no?
Yeah, I only see one.
Okay, cool.
Yeah.
So this is a cirrhotic patient, and this is a study from just about 11 months ago, and patient came in, I think they were just screened for HCC, and you can see that there's this kind of ill-defined hypodense, this is the delayed phasing, this is the hypodense kind of area. When we look at the arterial phase, you can see that this area, again, this, kind of very poorly defined, nothing very aggressive. You can see that there's a TIPS in place. And this was read as, probably an area of focal fat. So the patient came back 6 months later because, once, probably area of focal fat indicates that, that's Lyrett's 2. So they went back to the Q6 months follow-up. And again, patient had kind of this ill-defined lesion.
Victoria, would you have recommended an MR for this? I feel like, there could be a cholangio there.
Wait, do you want me to just go through my thinking or how actually things happen? I did not read this case. This is a...
Victoria, can you do both? I'm very interested in both.
Well, no, of course I will explain, but... Well, let me just see. This was also read as focal fat, but I'll tell you what I would have said and why in a second. Patient came back a couple of days ago with abdominal pain, and this, the chest pain or something, you can see even on the chest, there's, huge tumor basically replacing the right hepatic lobe. They just had an MR sorry. Okay, sorry about that. So now you can see the extent of tumor, basically replacing most of the right hepatic lobe, invading the right, main portal vein, branches of the right hepatic vein. So this is a very bad looking tumor. So this is a peer review case, peer learning case. So there are several things that to be considered here. So when you go back, it's true, it's kind of very almost innocuous looking. There's really no arterial phase hyperenhancement. It is poorly defined. So, you may kind of, I can see where, I guess, the thought of focal fat may come in. The couple things to consider here. This patient has advanced cirrhosis, and having as cirrhosis advances, it is, the parenchyma tends to lose fat accumulation. And this patient had a CT from a couple years ago, and sorry, not this one. And there was really not a corresponding abnormality in this region. Now, this was done as a urogram, so it's not a full study for our purposes, but even here you can kind of see that, you can sort of make out maybe there was something here, but certainly if this part is either new or what do you call it, or worse. So whenever you see something new or worse in advanced cirrhosis, probably focal fat is not a great choice. So if I was reading this de novo, I probably would have called it LR3, which would make it a 3 months follow-up. I may have bumped it up to 4 if I felt like it because of the subthreshold growth. But at least it has to be 3 or 4. Potentially, if I was very astute that day, if I were reading it, I could have possibly said, okay, well, this is something more infiltrative, and if you have something infiltrative without tumor in vein, that goes into LRM category. So all those, but chances are I probably would have called LR3. So the follow-up study, 6 months after this, this story, this is a little worse kind of mistake, because if you really do look carefully, you see that there's already tumor in vein in this case. So 6 months after the initial study. So you can see that this has kind of a little more oomph to it, right? And then you can see there's a little bit of tumor invasion here and here. And if you look at the sagittal, it's a little more convincing. See that? Do you guys see it?
Yeah, Victoria, how much of your, do you screen a lot of patients with CT? We usually only use CT if they can't get NMR for some reason.
Well, we very often screen with CT or MR. So cross-sectionals, probably compared to other places, we don't do a lot of ultrasound screening. We do cross-section, CT or MR screening. Sometimes it depends on the insurance. Also, it depends on who's sending the patient. Most of our hepatologists prefer MR, but we have substantial number of CTs. Anyway, so those are the things that kind of it's a very unfortunate situation, because it's a bad cancer, but it also highlights an important point about HCC. HCCs don't tend to have a very smooth growth curve, meaning that they don't just double in time of whatever, and they're just kind of on this straight path. They often have a very indolent growth, sometimes we see cases where, a few millimeter change, and sometimes you may even think that it's stable, even though it's slightly kind of over time creeping up. And then it hits often it hits kind of a threshold and then just explodes. So if you don't, so it's a hard balance to, between overcalling and undercalling. But in this case, I guess the main points are, if a new area of focal fat in the patient with advanced cirrhosis is a very unusual or unlikely situation. So you should reconsider and then go into the table, or if you feel like if you were reading this and you felt like this is kind of small infiltrative, mass, then that would warrant LRM category. So at the very least, this should have been followed up at 3 months interval. Questions?
Hi, yeah, this is Teresa, one of the fellows at Mayo, Arizona. I was just curious if you knew what the AFP was on this original and then what it ended up being on the final ones.
I can look
if it was just elevated at all on this one that you're showing us.
Well, I'll look it up in 1 second, but our hepatologists use AFP very rarely, because if it's normal, it doesn't help you, because very aggressive tumors can actually have. So this patient did not have AFP until a couple of days ago, and it's 11,000. And AFP is no longer part of like a routine screening protocol. So our hepatologists don't routinely get AFPs as a screening tool. So there's no screening AFP at this point, and currently it's 11,000. But
it's interesting that the first one looked kind of, not arterial enhancing, hypo enhancing. So I would have thought maybe cholangio, but then with all that tumor in vein, looks much more like an infiltrative HCC.
Well,
in that case where I don't have the arterial enhancement, then the AFP can at the end, where it can help you just kind of clinch it. Like, okay, well, then that's definitely.
So interesting you should say that. If you pay attention to what the tumor looks like right now, a lot of these things have targetoid appearance, right? Which is generally a sign of cholangio. But again, what I think happened is the original tumor is just an infiltrative HCC. And then again, on hepatobiliary phase, you can see some of these areas also have targetoid appearance, like this one. So this is just, it's possible that some of this is a combined tumor. But, at this point, he's not going to be sampled. They're going to put him into the systemic therapy. Okay, so the next case is sort of a companion, but more of a, pat on the back kind of case. It's a great call, peer learning thing. Also patient with cirrhosis, also patient with a, with TIPS. So you can see here, patient has TIPS. And notice that, this kind of wedge-shaped area of decreased enhancement, in the right hepatic lobe. And patient's TIPS actually was, the main portion was thrombosed, this portion was open. And, it was kind of very strange looking area, kind of heterogeneously decreased enhancement. There was really no arterial phase hyperenhancement in this region, right? Hypoenhancing here. It's actually retraction of the capsule, right? So which is kind of make you think maybe there's some sort of finer fibrosis. And here's kind of triangular wedge-shaped area. Again, when you think about triangular wedge-shaped areas, you're going to start thinking about maybe some sort of vascular abnormalities, fibrosis. On T2, not underwhelming findings, right? Kind of more looks like fibrotic changes more than anything. On diffusion, not much happening. Kind of there's some artifact there, but still nothing grossly abnormal. And I think this was done with extracellular contrast agent. So this patient had pretty advanced cirrhosis, so we didn't use AVIST. So you can see that on delays, everything kind of equalizes. There's almost the fibrosis structure almost preserved. So the way I read this case was, to kind of describe all these findings, right, and say kind of there's retraction of the capsule, has wedge-shaped shape, kind of weird pattern of enhancement. So my thinking was that this is some sort of vascular combination of vascular and fibrotic changes related to chronically thrombosed TIPS. But it was still sufficiently weird looking that I said, kind of unusual infiltrative neoplasm should be considered. Even though, to be honest, until this case, I always thought that, I don't think I've ever seen a infiltrative HCC without any restricted diffusion. More focal mass like HCCs commonly don't have restricted diffusion, but infiltrative HCCs, I felt like they almost always have them. Anyway, so this was this is how it was read, and thankfully they decided they were going to sample this patient, and they did, and they did a transcaval biopsy where they blindly go into the cave and just kind of sample this area, and this came back as infiltrative HCC. So this is just another show how HCC can be quite sneaky and mean, but this was a very unusual infiltrative HCC case. Any comments?
No, that's a great call. I think I would have thought it would just took out some portal vein, like it was that TIPS had taken out some vessel, and then.
I was shocked when it came back as anything. And just to follow up with AFP, this is a path-proven infiltrative HCC. So this is pretty aggressive HCC. The AFP is 24. Oh, 14, I'm lying, 14. So AFP is 14. So normal or low AFP does not help you because very aggressive tumors may not be making AFP. So yeah, no, I was very surprised this actually came back positive because I was also thinking this is something, reactive fibrotic. I can't even tell you why I even mentioned it, but something about it bothered me enough to say, I can't really exclude infiltrative tumor. Although again, without diffusion, I was very low level suspicion. But more.
Sure.
This is another quick pat on the back. This was a prostate MRI case. And just quickly, just a reminder that we are responsible for everything on the scan, and check out this tiny little thing. It is a tiny little thing. It is oh God. Oh, so it's doing that thing, remember? Anyway. All right, well, this concludes my. Remember, it did that before once.
I found something always here.
Anyway, so I can't fix it. So, but you can see, it was also seen on the. Okay, hold on a second. Can I change the sequences? I can't. Okay, never mind. All right, but you can see here a little lesion
Not changing
here.
for me.
I'm sorry.
The sequence didn't change for me.
Oh, okay. Hold on. See, did it now?
Okay, kind of. Well, I see a coronal now. I see it on the coronal.
Okay, great. So just on the coronal, you can see this the same kind of little lesion there. So this was a path proven, actually high grade TCC, but it was still like at the without invasion.
So that's a nice example of maybe how MRI, if you have good distension, it doesn't look like it's invading the muscle there.
Right. It was right. Yes. Unfortunately, I can't show you the rest of it.
That's okay. Cool.
But
Victoria, did that thing enhance on the large field of view of the post-con?
So we don't routinely give contrast to our prostates anymore.
Gotcha. Gotcha.
Hypermetric, yeah. So I'm sure it would have, but we just don't we don't do contrast anymore. All right, so I guess my computer decided that this is enough for me. Actually, okay.
Okay, I'll share my cases, and if does anyone else have any? Okay, I'll share mine, and Victoria, if your computer reboots or whatever, you can get back on. Okay. Okay, so this patient presented with hematuria. You can see that there is something at the base of the bladder involving possibly the urethra. Here it is, kind of frondy looking. Here it is, kind of blurry, high resolution. And this is the pre. So you'll note that it has some T1 hyperintensity within it. and pretty avid enhancement. So any guesses? A little bit quite avid for some, like for a urothelial.
Pheo? I mean, a paraganglioma?
Yeah, great thought. That's what I was thinking when I saw this super avid enhancement, but it was not a Pheo. And actually you can see that they've got lots of bone lesions too. So this is some kind of aggressive tumor that has metastatic disease to the bones.
Metastatic cyst?
Nope, also a great thought. But I've actually never seen a gist of the bladder or urethra. Have you?
Yeah, I don't know. No, I don't know.
Okay, and the clue was the T1. I mean, we never could have called this prospectively, but in retrospect, the clue is that there is this T1 hyperintensity. Prodna says melanoma. Excellent. So this was actually melanoma of the bladder, and which we looked up. It's pretty rare, but it can happen. Melanoma is much more common in men of the penile shaft or the urethra when it involves the GU tract. And so I'm wondering actually if it's sort of like of the skin component of the urethra and kind of involving the base of the bladder. But yeah, it was really aggressive. These bone mets actually had shown up within a couple of months, and then now they have like lung mets as well. So this was just a bladder melanoma. So, or urethral, probably urethral melanoma.
Wow.
Mm-hmm.
Wow.
Oh, okay. Yeah, I know. I'd never seen that, and it was kind of scary, but it's going to be a path diagnosis regardless. This was a younger woman, like 30-year-old female, had some hemangiomas in the liver. I can show you we have an MRI coming up, but what do you guys think about this lesion that is either arising from or abutting the uncinate process? Christine says lymphangioma, and Manjul says serous. Good. So that's exactly what we were thinking. Could this be a serous cystadenoma? Although that, because it looks like it's nice and lobulated and maybe has these enhancing septae that are becoming more confluent centrally. We weren't concerned that it was we didn't think it was an MCN. It looks too lobulated and not in the body tail. So she got a MRI. This was what the MRI looked like. So it had this, it was very T2 hyperintense, very cystic looking. The central part did have some kind of thin enhancing septae here. And then one cool part that I thought was interesting was that this is the in and out of phase. So at the same level around, you can see that there is dropout in this lesion, which I thought was both like intravoxel fat. I thought this maybe at the edge was like, bulk fat volume averaging, but I thought there was definitely intravoxel fat here. So, so anyway, I thought it was probably some kind of lymphatic thing. And a couple of weeks ago, I showed that case of like a lymphoepithelial cyst arising from the pancreas that had fat in it and was resected and was a lymphoepithelial cyst. And my pathologist was saying like they often have debris, like keratinizing debris. So anyway, we think that this was probably a lymphangioma or a lymphoepithelial cyst. With both that intravoxel fat, this T2 hypointensity, and then this CT appearance where it looks kind of lobulated and hypodense. Okay, my next case is this one. So this patient has had a liver transplant, and this is like 1 month post liver transplant. So there's all these things going on in the liver. So what do you guys think, and what are you concerned about?
Like this is peribiliary necrosis, and we will check the hepatic artery patency.
Yeah, exactly. So this was multiple areas of biliary necrosis. And exactly, so the hepatic artery, you can see that this is a part of the jump graft, and it's patent proximally, and then right there it goes out. So this was hepatic arterial occlusion leading to multiple biliary bilomas. And at this point now we've got drains in some of them, but it's pretty severe and they're considering doing a retransplant. Rupa says that they had a case just like this. Yeah, it's pretty sad. And then my last case is this one. So this patient had this lesion in their left upper quadrant. Any thoughts?
Gist.
Looks like it's abutting like the jejunum.
Gist.
Yeah, good. So we thought this was probably gonna also be a gist. Gist can have calcifications in them. They can have central necrosis, etc. But actually, and then if we look closely at the liver, there are multiple liver lesions. And I think this is like kind of easy to miss if you don't narrow your windows here. But if you go to the MRI, it's quite obvious that they've got lots and lots of lesions in their liver. And then there's
carcinoid.
Yeah. So actually this turned out to be a jejunal neuroendocrine tumor, a very aggressive one. And these were all liver mets from their neuroendocrine tumor. So I hadn't seen a exophytic neuroendocrine like this arising from like the bowel. I would have thought that was a gist. Gist can have liver mets like this, but great to think of that in the differential. And then they did, even with metastatic disease, they'll often go resect the primary neuroendocrine tumor, whether it be in the ileum, jejunum, or even like a pancreatic primary, because they think that debulking the primary tumor can decrease the mets and you kind of make it liver-only disease. And then you can treat them with like lanreotide, everolimus, and then also eventually if it progresses, they can use like Lutathera, like PRRT, which is radioembolized tagged lutetium. So anyway, this was just a aggressive jejunal neuroendocrine tumor with some liver mets. Oh, and Christine said non-functioning PNET. We didn't think it was coming from the actual pancreas, but that's a good thought because that would be much more common than actually exophytically arising from the jejunum. But we thought it was, and actually in the surgically it was actually arising from the jejunum there. It was not from the pancreas.
Aarti, is there any molecular imaging on this case?
No.
Okay.
No. It's a fairly recent case, but I bet you they'll follow them up with dotatate scans. Okay, I'll stop sharing. Anyone else?
I can try.
Are you back up?
Yeah, let me try that.
Okay.
Okay, can you see?
Yes.
Okay. So just the last case. This was a young woman in her late 30s, early 40s who had myomectomy before, now wants to have another myomectomy. I'm not sure that's doable for her, but what I'm showing you is this. Look at this endometrium. Again, she's like in her late 30s, early 40s. So what do you guys think about endometrium?
Endometrial hyperplasia.
Oh, come on. Hold on, let me stop sharing and try that again. Hyperplasia, hyperplasia is the consideration, right? Because it's thickened. What if I show you post contrast? What do you think?
Like enhancing polyps, but with cystic spaces?
Yeah, so this is a really cool appearance of a polyp. And we generally see these polyps with cystic spaces in patients who are treated with tamoxifen, but I guess it doesn't have to be just tamoxifen specific. It's hard to see on SAG, so just kind of see this kind of enhancing color. Probably the axial has the best look to it. So this is just a huge endometrial polyp with cystic spaces. You can see it here. When they big like this, they have to come out. So they can harbor early neoplasm. This one didn't. And yeah, so but generally, you know, we see these cystic polyps with tamoxifen, but in her case, it was just a random polyp that had cystic species. Let's see if you can see.
And what's their, like, do you know what they're planning to do? You said they were planning to do a myomectomy, but they probably aren't now, right?
I don't believe you can with this degree of, I mean, what are you going to remove?
Yeah.
You know what I mean? Like, you know, this entire.
But are they considering euphy now or just hysterectomy, or you don't know?
I don't know. I mean, I assume she's very keen at keeping her uterus. So I would assume that she's going to try to go for UFE. But have you ever seen a success? Like, we do a lot of UFEs, and they will do it. But I'm just like, with this degree of thing, do you think it's going to be successful? I don't know. I mean, I don't know, right? And it also depends on her symptoms. If she's trying to get pregnant, I guess there's some value in trying to do UFE and maybe reducing the bulk. I mean, obviously the endometrial thing needs to come out. It has to come out before she tries anything. But if it's the bulk and just like having this bulky mass in your abdomen, I'm not sure how much UFE is going to help you here. So yeah, but it's going to be up to patient to decide what they want to do.
Very cool. Okay, anyone else?